Okay, welcome to this very special program which affects every one of us in our everyday lives, our health and our recovery, particularly after any form of surgery. As I mentioned, I'm the only genuine doctor here. The rest are all doctors of medicine and surgeons, and I'm a doctor of economics. And I know nothing about medicine, so I represent most of our viewers, and I do hope all our panelists will keep the conversation very simple. So we want to be non-technical, and just so that we can reach out and convert the messages from this book to ordinary people. How many of us have faced this? A family member or a friend has had major surgery, and the surgeon says the patient will be back home in 3 to 5 days. And all seems fine after the operation, and then suddenly a serious-looking surgeon walks up and says, "I'm sorry, there's been a problem, a serious complication." Those are the worst words of the English language. What we plan to focus on today is the core subject of this outstanding book. When a doctor makes a mistake in surgery or there are complications after an operation, how should these problems be handled? Unlike when an economist makes a mistake, who cares? Economists make so many mistakes anyway, it's actually the norm. But when a doctor makes a mistake, or when there's a complication after surgery, it's a matter of life and death. It's like a pilot flying a plane, and he has to go through a lot of rigor and a lot of checklists before he takes off. So it is a very crucial issue. Just 15 years ago, when complications happened after an operation, 20% of patients died. Today, largely thanks to the work of Dr. Guma here, that is reduced from 20% dying to less than 5% dying. Now that's a huge improvement. And the success is in Western countries. But what about what's the reality in India? We'll be looking at that. And what can we learn from Western nations and reduce the death rates after surgery in India? You'll be surprised to know how simple some of the methods are, and they're given in this book, to reduce death rates. But before we start this discussion, let me just say that this book has among the finest production values. Beautiful graphics, simple, and the design has been among the best I've ever seen among any book. So many, many congratulations to Oxford University Press. Also, with 95 authors having contributed to the books from 15 different countries, each of those authors at the top of their field, this book will become, I honestly believe, a global standard work of reference in the future. It's worth reading, it's worth buying, getting, and going through it, doctors and non-doctors too, because you always need references, and don't just be a Google doctor. Look at this book. Just to make it clear for the layperson, Dr. Nandi, complications and doctor's errors, what's the difference?
A complication is an unfortunate happening after any procedure, when the procedure has been done correctly. An error is an unfortunate happening when the procedure has been done incorrectly. So that is quite a good definition of complications, which I haven't made up myself, I've got from Dr. Guma.
Dr. Guma, you're the father of the global analysis of complications. And when you say 1 in 5 people who get complications die, and to reduce that from 20% to 5%, a lot of it to do with your work and work around the world. What got you into this complicated? A lot of people write about operation techniques, etc., but very few are focused on this important area.
Well, the first step was in Amsterdam that we tried to analyze our data for pancreatic surgery. And we are the center there. So our mortality was in 1993 already, and our mortality was 2%. But we had 50% complications.
50%?
50%, 50.
Wow.
And I gave a lecture And during the coffee break, anybody came to me and said, well, what is happening in Amsterdam? I never see any complication. And I was thinking, well, are we stupid? We have 3 surgeons who only do pancreatic surgery. We are doing 50 or 60 per year in those days. The other hospitals are doing 5 per year, and they don't see any complications. So what is our mistake? And then I was able to analyze the data from the Netherlands. There was a registration already in those days of mortality. And these data showed that the overall mortality was 10%, and the range in hospitals was ranging from 2%, our hospital, to 100%. And then I realized that doctors don't realize themselves that they will have complications, and sometimes they make mistakes.
Right.
So the first step was that everybody should analyze the data, what they are doing. If you are doing a procedure, you have to look back, how did we do it? Did we have complications? If you have complications, the next step is, how could we improve?
Right,
and of course, not every complication is an error. For example, if you remove a gallbladder and you have a wound infection, well, that's a pity.
A wound infection.
And that's a complication.
Right, right.
But we know that you have to give antibiotics before surgery. And if you don't give antibiotics and you have a wound infection, then it is an error because you didn't do what is the regulation to prevent complications.
So one of the key things that you mentioned, you checked all the data, there's registration. The data was very important. So when you say a complication, there must be different grades of complications?
Well, that's the difficulty. In the first attempt, one hospital had 30% and the other one had 20%. And what is a mild complication, a severe complication? So that was the reason to start with a grading system. And many countries did, the US. Clavier, he was here last year to give the Berman oration, and he also had a new grading system. So there are many grading systems now in the world, and we try to have one system for everybody. Then you can compare the outcome of data and see if your complication rate is higher than the other ones. And then you have to check what is the reason for that, and to adapt your system, of course.
So the key to this in India is, how can we learn from the Western nations? I mean, do we have enough data? Do we have enough transparency? What do you feel? Is that something we could improve on?
In India, I think, at least in the field that I'm involved in, transplants, there is recording of data all the time. Because every transplant that we do has to be reported to the government. And also the way it has been successful, particularly because most of transplant is driven by private sector. And for an operation to become successful where somebody from the family donates, pays a huge amount of money, then you must be doing something good somewhere, otherwise that operation will not become popular at all. In fact, if you look at living donor liver transplantation in the US, where donor deaths, and because of donor deaths, the operation has completely gone out of fashion there. Yeah. Whereas within India, it seems to be increasing every day. And in fact, last year alone, we did 300 transplants in a year. So obviously, we must be doing good somewhere. And therefore...
Well, I mean, I would question that a bit. I mean, we are not, as Indians, very good at data, especially economists, but anyway, even medical. And to say you must be doing something good, the alternative is pretty bad, right? Alternative for somebody with cirrhosis is death. So they will try for anything. I understand you have to report to the government, but do you really minutely record everything you're doing, checklists, whether you've done this, done that? What happened, what level of complications you had, what grade, I mean, maybe you do it, but generally, talk about India in general.
Perhaps what has happened, of course, because at least I'll only speak about liver transplant.
But around the country, not just around
the country. Yeah. What has happened is that it's a very lucrative venture for hospitals, and a lot of hospitals are now keen to start liver transplantation. And many places, I know they have done it, and with very bad results as well. So that's something that with the Indian Society for Organ Transplantation, we are looking at trying to regulate.
So when you have bad results, you don't give the data. That's the best part.
It's up to the individual centers to report. But we all, in the field, we all know who's doing what is happening where.
Right. But there's a bit of asymmetric information. The doctors know a little more. Do you think that's an area we could learn from? Get better data. Make it public, be transparent, let it all be analyzed, even if it could be detrimental to yourself.
Yeah, so I feel that if you actually look at Indian surgery today, unfortunately the whole emphasis is on numbers, the whole emphasis on performance, big operations.
Right.
I don't think it will come from the surgical community, hard data, because a lot of the work is being done in the private sector. It's very competitive. I think it will have to be regulated. Yeah, I think to depend on the surgical community to
That's a very good
on
point.
their own come out with this. We have waited for too long now, and I think what we need is
Voluntarily say I've done a bad job is tough, right?
yeah, I think
What
so.
about
And you're competing.
and you're competing and it's, as you said,
Yeah,
profitable and it's
so in the
market.
Netherlands they're not competing. When you have a nationalized health system,
Of course they're competing. I mean,
We
you
want
still,
to, of course.
not in the way we compete. Not in the way we compete.
We
In
want
the
to be
sense-
the best center, so we are competing. The best is center in outcome, so we're still competing each other. I will show you later on a slide that we are really competing each other every year in the Netherlands. To
right.
be honest.
One aspect is the government regulating. Why can't insurance companies insist you give data before they actually compensate? Is that possible?
Well,
Because I worry about government being involved in anything.
We have an enormous fight in the Netherlands that the insurance companies want to have all the data. And we mentioned that before transparency is the item, of course. And I agree that you should have transparency, but transparency is only possible if you have adequate data collections. If you are comparing different centers, then you are comparing apples and oranges. So everybody has to use the same system to validate the system, that your data in your hospital are validated. Right. And then the next step is transparency for the insurance companies. But the insurance companies in the Netherlands want to have these data. The next step is that they are deciding that they want to work with one hospital and not the other hospital because of these data. Right. So it's important to have adequate data collection.
Shomran, you have been a data fanatic. I mean, you're a fanatic on a lot of things, but you've certainly always been a data fanatic. Many of your publications have actually talked about, used masses of data. I think I remember you once saying that you follow this checklist, that everybody should have a checklist, the Gawande's checklist. And you tested whether checklists work?
Yeah. A simple way of minimizing complications is to have a checklist which is done by the WHO, World Health Organization, popularized, started by Dr. Atul Gawande, who is a professor of surgery in Harvard. And he showed published in the New England Journal of Medicine, which is the best medical journal in the world, he showed that if you check name, age, sex, which side is being operated on, what kind of operation is being done, what steps will be taken of the operation, before the operation, during the operation, after the operation.
What kind of steps, meaning things like simple things, wash your hands, have you looked at the CT scan before the operation? Simple things like that. Have you looked, tick.
Simple things. And this, funnily enough, brought down the mortality after people using the checklist by 30%. And someone wrote an editorial which said that there is no innovation in surgery which has brought down the mortality so low.
I mean, mortality being number of people who've died, the death rate by 30% just by having checklists?
Yeah, and what we did in our great hospital, Sir Gangaram, we did a similar study where we did, one of the authors of this book, in the book who was written on checklists in developing countries, we looked at something like 500 patients consecutively. Half the people had checklists done and half the people did not have checklists. And funnily enough, the mortality, the death rate was 30% less.
Same as the global standard.
Interestingly, the people who filled in the checklist well had a higher, much less mortality than the people who didn't fill the checklist well. So a simple thing like a checklist is very good.
I mean, that really is...
Yeah, I just want to add something. That's a very Western way of looking at things because, you know, the person who sees
Whatever works, how does it matter where it comes from?
You see a patient on a particular day, then you go on holiday. And your anesthetist who is supposed to see that patient is also gone on holiday on that particular day because he's posted for surgery 3 months later. Whereas here the patient will insist on seeing the surgeon and the anesthetist before the operation whom he's seen in the clinic. And so therefore you must look at the different ways of practicing medicine.
What's wrong with having a checklist?
Nothing wrong with the checklist.
I mean, because it's Western.
No, there's nothing wrong with the checklist. But the error is not in the checklist. The error is the person who's seen the patient has gone and leave on that particular day. The anesthetist who's supposed to do the operation has gone and leave on that particular day because it's his time off. So this is a very different way of practicing
I do remember,
medicine.
actually, I would like to dispute that because even Dr. Gawande's research on childbirth mortality in UP, a chest list of 20 items improves how many children live much, hugely increased. Works in India, it works, the research has shown it. Why say it's Western? What do you feel?
I agree with your remark. If the surgeon is seeing his
Absolutely.
patients the day before and on the outpatient clinic also, and the same anesthesiologist, and it's an excellent surgeon, you will reduce the number of complications because the optimal surgeon has his checklist himself because he is checking, did I think about antibiotics, what is the age, and did I stop the medication or change the medication? But we have also be aware that even the best surgeons are sometimes making errors. And the checklist is reducing these errors because if sometimes you will forget anything, and the checklist is to prevent that. And every surgeon is sometimes making an error or doesn't think about antibiotics or anesthesia things and so on. That's the reason that we did also the trial in the New England Journal, and we also found an enormous difference in outcome after the checklist.
Another issue, if I can bring you in on technology. How do you do all this in India with limited resources in many places? Some places, of course, do have the best technology, and you can just replicate the West. But trying to do post-operative complications or errors with limited resources, checklist would seem one simple way, that no cost. What other ways are there?
Yeah, so the Indian scenario, as you said, is very different. Gangaram is not exactly representative of the average Indian hospital.
You mean it's Western? That's the nicest thing you've ever said to Shomaron.
So once you move beyond Delhi, once you go into the interiors, obviously the scenario is very different. So the chapter that we have contributed to the book, and my co-author Dr. Roy is also here, is actually looking at how surgeons confront the problems in low and middle income countries. And it's a huge challenge because you get these Western algorithms of what is to be done. For example, the algorithm will say that you get a CT scan done in an hour or 2 hours, but there is no CT scanner available for 8 hours. So what does the surgeon do? And we, in fact, will be surprised, even in Mumbai city, in one of the public hospitals I work, my instructions to my residents is, if you don't have a CT scan, if you have a doubt of ischemic bowel, open the patient, because those 8 hours are important. So we need to adopt the algorithms too. So I think we try and we innovate. The information asymmetry that you mentioned is huge in India. Is huge. So our patients have a lot of faith, a lot of trust.
Faith and trust is non-scientific, if you ask me. We need to get a little more rigorous with all kinds of... I mean, there's a lot of work to be done in India still. I just wanted to ask you, your book is a global book. It's got examples from all over the world. But what about, when you look at it for India, sorry, this is being recorded in India, so that's a special interest here. We have different diseases as well, right? So can you apply a lot of that to the special cases of India?
I think that really, I mean, as I always say again and again, was trained abroad and came back to help the poor in All India Institute. And I found, and people said, oh, you're trained abroad, you can't fit into India. I think this is completely wrong, because what you are trained at is not, rote learning in diseases, how to deal with diseases. It should be an approach to a problem. And this is where Western countries and the best hospitals actually do well. They approach a problem, how can you do the best you can with what you have wherever you are. This is Theodore Roosevelt.
I want to just start, we're running out of a bit of time, but I want to go to an area which you have actually been the father of as well. You've been many innovator of many areas, and this is the impact of centralization and greater volume reduces death rates or mortality. How is that? Explain that to us.
It's not the surgeon only. Of course, it's helpful if the surgeon is an experienced surgeon. That's for everything you're doing. If you are doing other jobs, experience will help. But we have found that the institute, the structure of the institute, is more important even.
Really? That
So
affects
all
mortality.
the other people, so it's not only the surgeons, it's the anesthesiologists, it's the intensive care, or it's the radiology doing early CT scans or doing interventions.
Right.
So it's the entire team, and it's the communication between the members of the team, which is more important than the surgeon alone.
Right.
Of course, he has or she has to have experience in doing the procedure. In particular, if you are doing liver transplants, then of course the first important fact is the experience of the surgeon, but recognition of complications after that. The nursing staff in the ward, they tell me, sorry, your patient is not well. And the youngest resident is telling me, well, he's doing well, she's doing well. And the nursing staff is coming again and said, well, because they have experience in these patients or in all kinds of patients. So it's the entire team and the combination, the coordination of the team, which is helpful.
Right.
And if the team is working, if the structure in your hospital is working quite well, you will see that you will have a reduction of these things.
Right.
And that's better in larger units.
Just looking finally at the roundup as how do we improve surgical quality in India. It is already at a pretty high level, but obviously there's a long way to improve, and I think data transparency and big data analytics, all that can help. What about this kind of surgical, you mentioned there's a book, chapter about surgical quality improvement program done by Dr. Pitts, was it?
From Johns Hopkins.
Johns Hopkins. Where, can we have something like that, where there's a general standardization, a committee that looks into all?
I always say that in India we just don't have data. If we had data from all over the country to see what kind of diseases we have, what kind of operations are done, what is the mortality, the death rate, we'd go very far.
Right.
For instance, I was telling someone that there was a person called Dr. Malhotra who was in the railways. And in the railways, every time you take time off, a doctor has to sign a diagnosis. So he collected all these diagnoses from the whole of India. And he found, for instance, I was interested in bleeding, vomiting blood. And he found that vomiting blood was due to liver disease in one area, like in Chennai, Delhi, and in Srinagar, it was due to duodenal ulcer. So there's huge differences and very interesting. Needless to say, you have to have an English missionary called Frank Tovey who looked into this and said that maybe it's all related to the diet they have. And we have a huge, diverse population. We can do a lot of research.
So
Because
of the data, they could link it with diet and solve a lot of issues.
And we are interested in electronic medical records. And I have a conflicting interest because we do RAXA.
Right, it's also a very important way of actually maintaining
electronic medical records is the way to go in India because it is, there's no paper, it's easily portable, and you can access it very easily.
Just one very small issue before we round up. Who owns the data? The patient, the government, how private is it?
Of course, every patient can have the data. So if
Their
the
own
patient
data.
is asking the data, we will give all the data because it's the patient.
Patient owns the data, or the
patient,
doctor.
and well, they can have the data, and the data are in the registration of the hospital. And sometimes you have to give them
Permission to use it.
Permission to use it. And if the patients are not giving permission,
Because I
you can't
noticed
use
at
it.
Stanford, they're very close with their data. They're very careful. The patient has to give permission. It's all under
Of course,
password security. Just finally round up. 2 points from this book that you learned on how we can improve in India.
So the first, of course, is that we know now that the world's attention, the rest of the world's attention is shifting from just doing operations to looking at how to do them better. And I think the Indian surgical community needs to move towards that.
How to do them better and reduce complications after surgery. And this book is a major contribution in that.
That's right. And I think it's of special importance in India, special relevance, because our patients are paying out of the pocket. So a complication for them is catastrophic expenditure. Like it can ruin families, families can go bankrupt.
Who should pay when the doctor makes a mistake?
So this
That's
is
another half hour.
Okay, I think you've answered that. Yes, sir.
I think one of the
2
important
points that you've learned from this book.
Yeah, I think we learned lots of things from this book, mainly that not only me, but most other surgeons also have complications, as you've seen, huge list of them. But I think one of the important points that I've always felt that there are no national guidelines in our country at all for anything. There's a very simple thing when I was in UK, they was said that no emergency operation should be done after 12 in the night, it should be done in the morning, except for, somebody's bleeding or something. And that itself reduced the complication rate markedly. So we need to have from the government, from people like Dr. Nandi, national treatment guidelines. We did one thing for FICCI once, for national standard treatment guidelines for liver diseases, and it's still lying somewhere on the website. It's not been adopted by the government. It's still, so every doctor in the country does things on their own. There's no national treatment guidelines at all for this country.
2 things that the message you want to give from this book. I mean, it's a wealth of information, but just distill it down to 2 main points you think should definitely be widely disseminated.
Residents should use it.
Sorry?
It's important for the residents in
Residents
surgery.
must use this book.
Yeah, because it's not only very specialized, it's also simple. What you should do if you look for patients who are ill after surgery, what is the decision? So there are many aspects important for prevention if they are trying to learn surgery and if they have complications. So the book is very important, I think, also for residents in surgery and young fellows.
Right. Dr. Nandi, 2 main reasons you wrote this book and you'd like to see a couple of things implemented.
Well, I want to make a statement, and I think that all because of my co-editor, Dr. Guma, and Oxford University Press. I'm an Indian. I say everything chalta hai. But the Oxford University Press, very interested in all the photographs, the number of pixels, and Dr. Guma constantly wanted to have an introduction, conclusion. So in the end, I think we've, although I say it myself, have produced a book which is probably the best book in medicine out of India. Why is it? Mainly because of Dr. Guma.
I think we
and
can give a
Oxford.
round of applause for that.
But it has the best authors from so many different countries, and they've been edited and re-edited so many times.
It is of the
And it's
highest
something
global
to be
standard.
proud of. It will be a reference book. And I think that all residents and all surgeons should read it.
Right.
But
Not that
realize that Dr.
I'm-
Nandi started it, so you should.
I'd like to end by saying,
He did it.
I'd like to end by just giving you sympathy because he was your co-author and he must have troubled you a lot.
We had 1,000, Doug Guma said there have been 1,000 emails exchanged between him and me alone.
Yeah, and he's
Data.
expecting an answer within 12 minutes, so that was difficult for me.
Thank you all very much indeed. Round of applause for everybody. It's a wonderful book. Go out and get it. It may be a bit intimidating, complications after gastrointestinal surgery, but that is 60% of surgery, right? Gastrointestinal. So it will be relevant for all kinds of surgery. And complications happen in all types of surgery. Thanks very much for watching.